Afternoon and welcome back. I hope you had a nice walk to see Lincoln. My name is Carlos Crespo. I'm a member of the Planning Committee. I'm also a professor in the OHSU PSU School of Public Health and a Vice Provost for Biomedical Research. I'll be moderating this session. Our session this afternoon is entitled Lessons from the Field, Achieving Equity in Obesity Through Community and Public Health Approaches. If we think about our major health problems today, violence, drug addiction, obesity, these are not exactly medical problems. These are community problems and therefore require community solutions. This morning we heard about the prevalence and estimates and variety of other data, and I appreciate the Academy for taking a whole day to talk and go in depth into this topic of equity and how it has a disproportional impact in some communities. We have 4 wonderful speakers today. They will be presenting on approaches to addressing determinants of inequities related to obesity, including approaches that have resulted in improved weight for those with overweight or obesity. I want to remind everyone that we will hold off questions after the speakers, and then we'll have time at the end for questions. Hopefully we'll have enough time, approximately 25-30 minutes. Our first speaker will be Dr. Debra Haire-Joshu. She's a Joyce Wood Professor at the Brown School of Medicine and Director of the Center for Diabetes Translation Research and the Center for Obesity Prevention and Policy Research at Washington University in St. Louis. She will be our first speaker. Please give me a round of applause.
Which one? This one? Pointer, so this advances. Okay. Thank you very much. I'm really grateful to be invited to present here, and Shariki told me I had a tough act to follow, and I know I do. So I don't feel any pressure, Shariki. So I'm going to be talking about some of the approaches that we've used in scaling up some interventions. And I want to start with my disclosure that the work I'm going to be presenting has all been funded through the National Institutes of Health. I've done this work for a long time, and most recently, and some of this came about with a paper that Bill Dietz published a couple of years ago that I said many times. That's one when I saw, I thought, gosh, I wished I would have written that. But it was about reversing the obesity epidemic and looking at different targets. I primarily work with mothers and children and underserved communities. And we focus our efforts on young women, primarily between 18 and 40 years of age during the childbearing years. And you saw from the data this morning that this is a really high-risk group for obesity. Really high-risk group. They double obesity in this age group when compared to children who've been leveling off some. And we tend not to pay attention to them because they're not seeing the doctor a lot except when they're having children and they're running around trying to get their jobs going and they're chasing kids and all of these things. So women kind of get lost, and especially women of color, women who are struggling with poverty, it's even more pronounced. So they're very vulnerable to weight gain versus other life periods. And because they're so busy, they have so many things going on, there's limited reach of very efficacious interventions. The diabetes prevention program is one of those interventions. It's been around now for 15 years or more. And we know the lifestyle intervention in the diabetes prevention program can prevent or delay diabetes 58% of the incidence. And so we've got this intervention that was very efficacious, very clinically relevant, that really has not reached populations that need it effectively. And we know from looking at the National Diabetes Program that women are half as likely to enroll and less likely to attend even one session. So a very high-risk group. We took this to heart. And in St. Louis, just to give you some context, which is where I'm from, we work in the St. Louis region, which here's areas of poverty in the St. Louis region. And this is from a colleague of mine, For the Sake of All, a report that he's done, Jason Purnell, which really describes the St. Louis region in terms of discrimination, in terms of racial inequities, and all of the things that we were talking about this morning. And you can see, if you just pay attention to the reddened area has the highest level of poverty. This is the racial breakdown in St. Louis and the region that I work with. The reddened areas has the highest proportion of African Americans. So there's very much disparities that exist in the community that I work with immediately. And how we deal with that in an equitable fashion to eliminate disparities is critical. It also affects mortality. And this is the same regions, and if you look, and I do this pointer, but I'll probably blind somebody. Let me see if this pointer works. In one area, you can see the age of 67 is the death rate, and a few miles over, the death rate is 85. The death rate of 67 has a very high proportion of poverty and a very high proportion of African Americans. The death rate of 85, reverse. So we're talking about social determinants that affect so many things, in addition to the fact that the people who need the interventions can't get them for a whole variety of reasons. So myself and my colleagues and our team took this to heart and started thinking about how do we translate these interventions so they can make a difference? How do we compensate for these disparities? My colleague Felicia Hill-Briggs at Hopkins has that great description of compensatory interventions. I'd love to do something other than compensate for the social determinants, but they are life-saving at some point. You saw the death rates. And so we were looking at ways we could compensate and address the social determinants in a way that we could get these interventions to the people who need it, in particular these young women who have these young children that it also influences. So we began working and looking at home visiting organizations, and that's because home visiting organizations take the intervention to the mother. If they're available, they're accessible, they're usually affordable, they're convenient. We were talking this morning, you've got a lot of stuff going on. You're not going to run to a 16-session DPP no matter what. You're just not going to make it. And so it's reach that was important. So they meet family priorities, they address essential conditions as part of what they do and essential needs, and they provide reinforcement, ongoing support for that family over time, usually until the child is older in the home. Challenges are, they're usually not healthcare focused because that's not the issue. The issue is social determinants. So how do you embed a healthcare intervention in a non-healthcare organization? You have to meet criteria for reimbursement. They just can't go off and do anything. They're not rewarded for working with you. And you have to figure out what and how to include that content. We began working with parents as teachers, which is one home care, national home visiting program. They have a national center in St. Louis. And their mission is to promote optimal early child development by supporting and engaging families. They have a standard evidence-informed curricula, and they do trainings for parent educators. They certify these parent educators who are all from the community where they reside, and they teach them around child development and home visitation. They've trained almost 5,000 right now. They visit the family from prenatal until the last child in the home enters school. So you've got ongoing support for that family. The families with high needs get up to 25 free home visits a year. That's a lot. Now, everybody doesn't necessarily need that, but that's what they can have if they're high needs and they want to do that. It's free and it's paid for through state and federal funds. They have over 4,700 sites across 50 states. They currently serve over 188,000 parents and over 250,000 children. And they are a diverse group. They have a program specifically for American Indians, and they're diverse in serving Black, Hispanic, and white populations, is the data here, and a small number of Asian populations. For me, St. Louis has many needs, but this was a national network. And so what you're talking about is a program that has a local focus. They deliver it locally. The parent educators are local. but it has national reach. And so for me, at this point in my life, actually a little even earlier in my life, I thought, wow, then we can actually have impact outside of the immediate region to really make a difference. It was very exciting, which maybe I need to get a life, but I thought that was really exciting. So we took the diabetes prevention program, which, is a session a week. It's very, intense, coaches, context, supervised, a session a month of group support, and thought, how are we going to get this in? Well, it was interesting. We were talking about community-based, community-informed research. We worked with the parent educators. We would present the science. They would decide how it would get in. I couldn't possibly begin to do what they did. If I would have had them when I had my children, I'd have a lot more children by now, because they do so much around a strength model, and they do so much around working with what you have and making you feel good and about yourself and everything that's going on. And they decided how to take the information we had and embed it within the practice they were doing. So we did the science, and they did the practice. We were charged with, we had mothers who had overweight or obesity and also had a preschooler. And we were looking to see if regular PAT, which is pretty intense really, or PAT plus what we called healthy eating and active living taught at home, which was embedded information, would make a difference. The key ingredients were boiled down. We took each of the sessions and boiled them down to the most simple, concrete, simple is not the right word, concrete, I think behaviors was probably it. And then again, worked with the educators to adapt the content. It was a lot about parental modeling, so we'd make a difference with the child as well. And the rules, the principles that guided us was they decided when they delivered it. We had the sessions, but when they went into the home and there was something else that needed to be done, they did that. So there may have been 25 visits. They may have done 16 visits. It had nothing to do with the DPP. They made that decision, and that was a principle in working with them. It's family strength, solution-focused model, not a deficit model, and very flexible delivery. So it's just some quick data. We had 179 moms, and they were around 32, 33 years of age, all overweight or obese. About 42% were primarily African American, and then low income. These are just select behaviors. It was too crowded to get some of the, we didn't see some change in other behaviors, but the main behaviors we saw changes in were around sugar and calories, some of the specific eating behaviors, reducing sugar-sweetened beverages. We saw some real improvements in physical activity with walking, and a variety of information around that. But interestingly, 5% weight loss, which is clinically significant, we saw that at 24 months, 11% versus 26%, with an embedded intervention that they delivered as they saw fit after they met the social determinants. And we saw reduced waist circumference. This was the graph that got us really excited, and that's because if you look at this, the 12-month mark, you can see that it was a significant difference at 12 months in weight, but look at the weight that's going up on the other side. On average, there's about 1 kilogram a year people pick up. And so after 10 years, you can imagine how much weight somebody's going to pick up. But look at 24 months. Our intervention group still having a slight decline, which was significant, but the other group gained about 11 pounds. And so you see this climb. They're young women. They were childbearing women. They retain weight sometimes for pregnancy. You see the risk. And this was with a group that's also getting an intervention that's helping them, the regular PAT. But that shows working with these groups and working within their rules could make a difference. It takes longer, but it can make a difference. It also showed that working with them and letting them deal with social determinants first made a difference. You can't change a behavior in an environment that's not allowing you to change the behavior. We just received funding. Rachel Tabak, who's a D&I scientist with us, is leading a team to look at disseminating this nationally through parents as teachers to see if we can have that impact and to figure out what about the dissemination implementation approach works or doesn't work with a very diverse sample, including Hispanic families, including African American. I don't know if we have American Indian, but possibly if we work with the FACE program. But we're going to look and see what happens and what kind of impact we have when this intervention is delivered nationally. The second program I want to present briefly, because I'm running out of time, it was also done with parents as teachers, and this was part of the Life Moms Consortium, which was a consortium of 7 sites that looked at excessive gestational weight gain in underserved populations. And we were one of the sites at Washington University, and we worked with African American women with obesity, overweight and obesity, who were pregnant. And they lived in the sections of St. Louis that I showed you on that map. Very high poverty, very high stress. We had 276 women, 54% single, 92% were in poverty, and I mean really severe poverty. And what was very interesting is that in 4 months, half of them moved at least once, another 12% had moved at least twice, and another small percentage had moved 3 times in 4 months. So the issue to me was housing, stable housing, as opposed to other things, and crime was way above national average. So our parent educators from the community were going in working with these mothers to try to embed diet and lifestyle to help them maintain gestational weight and improve baby outcome. So we did that compared to regular PAT through 10 prenatal and 12 postpartum visits. Young moms, about 25 years old, all overweight or obese and poor. We saw a significant difference in weight gain. Babies did well in both groups, but we saw a significant difference in gestational weight gain per week within guidelines, and we saw a change in body fat. We also, though, saw the return to baseline weight, and all of these young women were already overweight or had overweight or obesity, but 21% of the regular PAT group got back to baseline, 38% of our moms with the intervention got back to baseline. An embedded intervention which dealt with trying to get them into stable housing first, trying to deal with the food insecurity first, and then dealing with the intervention. This was the difference in our weight, and we're seeing the same kind of pattern where, yes, when they had their babies, they gained less gestational weight, but then at the outcome, what we see is that we've got almost a 7-pound difference, and we're starting to see some extension between the top and bottom line, where we think we're going to be seeing some of what we saw before, that they tend to gain or retain more weight without the intervention. This was a very low-cost intervention, going by parents as teachers guidelines. This intervention cost about $85 extra for training, but because it was all embedded, there really were not additional costs beyond that. There weren't additional visits, and it was very, very sustainable. We are waiting to hear about funding for this, to also do this in a national trial to disseminate it across a very diverse group. I think the check's in the mail. We don't know, we haven't seen it yet, but we're hoping the check's in the mail because we think this could truly have an impact in reaching women in need. So in conclusion, I call them non-healthcare organizations. I'm not real fancy with I think there's got to be a better term, but I think we have to look, we talk about transdisciplinary groups. We need to look at other organizations. If we're going to do real world, we need to work with the real world and organizations in the real world, which means you give up some power and control and you change how you do things, but that doesn't mean it can't work. I think it's a roadmap to at least approaching health equity. I think we need to do long-term follow-up. If you looked at our data at 12 months, it would have looked much less impressive. It takes a while to put on weight. It can take a while to take off weight, especially when you're in an environment that doesn't help you to do that, and especially when you're dealing with a lot of other life events. And I do think that we want to bring these interventions to scale to have impact, and we need to do it in a way that social determinants are the issue. The diabetes, the obesity that we see a lot is a symptom almost of what's there. And so if we deal with the social determinants, this is in a compensatory way. It would be great if we could do it in a macro way, which I think is our next approach, or it should be our approach now. We need to also do it so that we can bring it to scale so that it benefits all communities. Thank you.